It's a great pleasure to be here. There's no question, I think, that for a variety of reasons, which I'll skim over in the course of my talk, I think this is a particularly exciting era in cancer care. Cancer is only about 40 years old. Oncology, I should say, is only about 40 years old as a discipline. It's instructive to think back what it must have been like for Larry Eichhorn to see the first cures for testicular cancer using cisplatin in 1973. And we've learned a lot about cisplatin in the subsequent 40 years, but I think those patients, the immediate responses, no doubt, ushered in an era where that made an enormous difference to the lives of certain patients. The first solid tumour, when metastatic, that could be cured in effect, I think, or the first proof of it. And second is for us not to get so, it's sort of a bit of the Samuel Beckett saying, do not despair, one of the thieves was saved, do not presume one of them was damned. So I think there's challenges and opportunities in this area which we need to bear in mind. And just as we now think of the excitement of genomics and cancer, I think we need to remember that this isn't the first time exciting developments have occurred, and it's important that as scientists that we build on what we've learned in the past. So I'd echo much of what Jenny said in her previous talk, particularly about pharmacology, about which I'm very interested. So cancer is fundamentally a genetic disease. This is the reason why programs like Genome England have three focuses, one on developmental disorders, where I think there's an unequivocal argument to be made about the impact of genomics on management of children and neonates with clearly inborn errors, some of which are actionable and all of which result in expensive and very painful odysseys for families which have a lifetime of the consequences to bear. But it's a genetic disease. Cancer is the next cat off the rank. I think the evidence for cancer being translated immediately into therapeutic space is very limited, meaning that I think a lot of research needs to be done. And I'm one of those who believe, despite the fact that I'm invested heavily in this space, that this is an area for research, not yet ready for certainly direct-to-consumer marketing, in most cases not ready for public reimbursement. This is just some data from a paper we published recently about a disease that I treat as an oncologist, well-differentiated liposarcoma, showing the extraordinary rearrangements in cancer genomes and the sort of things that we can observe that we've never seen before that ultimately hope to lead to therapies. And I should say that in this particular disease there are two amplified oncogenes for which there are currently therapies in clinical development. It's one of the first diseases that I think will be treated by combination therapies which might result in eradication of the final clone, something that is the holy grail and is as yet very challenging for targeted therapies. And Simon mentioned the X10. This completely is, as you can see from the quote from Michael Schatz at Cold Spring Harbor, is a major game changer in genomics because it essentially democratizes the technology, taking it from an esoteric assay applied to a small number of samples and now applying it to populations at large, because the cost per sequencing run is now down to around 1,700 Australian dollars per genome as we perform it. And we can do this on 18,000 genomes per year. We've had the machine up and running for about 6 months. We're at 2,500 genomes, which is roughly 5 times the entire previous whole genome sequencing capacity in this country. What's going to come, I can't imagine, but I imagine this is somewhat analogous to looking down the microscope by Rudolf Virchow describing the cellular structure of cancer. I think it's that dramatic a change, and I think like any dramatic change, I think there'll be very broad protein consequences, much of which we won't understand for years to come. One of them is, of course, about molecular pathology, and I'm not going to say much more than this except to say that the molecular classification of cancer is currently overlapping with the histological and cellular classifications of cancer, which we've had for 150 years. This stuff is only about less than 10 years old, so one can anticipate that this is going to undergo considerable changes as it's applied and mapped against the clinically important consequences of this classification system. But for advanced cancers, one of the challenges I think is going to be how do we have one molecular classification, estrogen-dependent cancers of all types, no matter what their histology. Clearly at the other end of the spectrum, if we're trying to remove and cure a tumor, you need to have a surgeon who's capable of doing thoracic surgery, and that's going to be very organ-specific. I think there's going to be quite a complex rearrangement along the cancer journey. But there's no doubt that these therapies that are based around some molecular therapies, whether or not this applies at the population level, certainly at the individual patient level, this sort of thing is getting out of the public space. And that generation of knowledge is building a huge public appetite for application of these technologies in order to get access to drugs like this, therapies like this with the sort of responses that we see, even if they're not 100%. This is rational hope for a population. As you can see in this particular case, this man is going to die of his disease and probably will have died from this disease because these drugs don't always work in an enduring way. In fact, rarely do. This is the regorafenib data for metastatic melanoma that's BRAF positive. You can see that this classical elliptic sort of extension of survival, but that ultimately people go on to die from their disease. And I think another driver in the current context is immunotherapies. The immunotherapies are so exciting for those of us who work in oncology precisely because this particular shape has been changed for a subset of individuals with immunotherapies. Melanoma, for example, there are a combination of immunotherapies that result in the tail of the curve extending out and not reaching that x-axis, and that's incredibly sort of exciting in the same way that Einhorn cured people of metastatic testicular cancer. So metastatic melanoma potentially looking like it may be controlled in the long term by immunotherapies changes the landscape, and I think is the next wave of excitement. Not to say that immunotherapies won't be interacting with genetics, as has already been described, but I think understanding how cancers manipulate the immune system will be a fundamentally genetic exercise. But enough about that. The cancer journey goes on really from the point at which people are at risk, where we have opportunities for prevention. There's the diagnostic issue, which we've discussed briefly. Therapies, typically what we're talking about is therapy in the setting of advanced disease, so in this phase here, and ultimately going on to death and palliation somewhere in there, symptom control. For those people that are cured, there's a survivorship issue, and of course these different phases have very different impacts upon our economy and the proportion of patients that may benefit, something I'll touch upon later in the talk. So let's pan out dramatically now and forget about the molecular biology and targeted therapies and individual patients and anecdotes and talk about cancer. So this is a very significant burden. You're well aware of it, 1 in 2 million died in 3 women, 42,000 deaths in 2010, 3 in 10 total deaths. The overall survival is 66% or so for patients newly diagnosed with cancer, and that has improved. I mean, it's important to recognize there's been about 20% increment in survival compared to the 70s. So that's actually improvement with the impact of various changes across cancer care more broadly. And it is a very substantial cause of both loss of life, loss of productive life, and the burden of economic burden for the community, some of which is illustrated here. So if our GDP is on track for 286 billion, health budget is going to be around 12.5% of that GDP. Cancer accounts for 19% of the disease burden, 29% of deaths, but only 7.2% of health expenditures. And the projected expenditure by 2030 is going to be around $10 billion. This is a big, and that's probably an underestimate because, as was pointed out earlier, the impact of the pharmaceutical sector and the high-cost drugs and the waves of optimism and hope and the political pressure that we've brought to bear to make these drugs available is probably going to expand rather than contract, just as knowledge expansion is expanding at a rate that is non-linear. So I'm going to talk about something completely different. I'm going to talk about the idea that surgery can be essentially used more effectively. What we've figured about pathology. let's try to cure a cancer. And basically, at this point, it's pretty much incurable, I'm sorry to say. And I see people like this. So this is not a laughing matter. What we try to get is somebody who's like this. But I mean, this is going to be tumor in the lung, that's going to be completely undetectable unless we're doing screening with CT scans, for example, which is something that's beginning to be tested in the public health space. But how do we identify that, and how do we do that in a cost-effective way? And the reality is cancer risk is not random. Everybody in this room has a very different risk of having cancer. And that's been known for some time. This is a paper from 1930 from a family that had been described in around 1912. A lot of cancer in this family, although it may not be a recognizable pedigree pattern. And we know that breast cancer particularly is well recognized to have a strong familial component with women who carry mutations in BRCA1 and BRCA2 passing on a very high lifetime risk to those of their female progeny that carry the risk alleles. But this has been regarded as a relatively esoteric exercise. And really, in our familial cancer centers and our community at large, the overwhelming number of patients that they see are in breast and bowel cancer. it's about 80% of clinical attendance, although it's about 22% of all cancer. So there's 78% of cancer, which for some reason is either not genetic or is not being sort of developed as well as this. And I think that's going to be an area that democratization of genomics is going to change in the next little while. So essentially, I think what's going to happen is we're going to go from this clinically identified risk based on familial patterns to this enormous burden of genetically identified risk, which on current estimates goes from under around 5% of cancers currently, and this is total cancers, for breast or bowel cancer, so a much smaller fraction of the total cancers, to being around 10 to 25% of all cancer, which in this country is 10 to 25,000 cases per year, and therefore not a trivial or esoteric or boutique problem. To get an estimate of how much of the cancer risk is germline, this is probably the best data. Only the Scandinavians could have generated 45,000 mono and dizygotic twins and looked at them over time to assess the relative risk, the relative genetic and environmental contributions in this perfect experiment of nature, monozygotic and dizygotic twins. And you can see the estimate about heritable proportions differ by cancer type. It's important to note that not all cancers are genetic. I mean, cervical cancer is a viral disease, and the genetic contribution in this study is virtually none. But it's interesting that prostate cancer, a cancer that occurs in an older population of men, typically has almost a half of its attributable risk as genetic in origin, which is fascinating. It suggests that age of onset alone is not a good criterion for defining likely genetic burden. For prostate cancer, it means that a 50-year-old only gets prostate cancer and they will be carrying risk as opposed to a 20-year-old. But for diseases like stomach cancer and so forth, breast cancer, about 1 in 3 of one-third of risk is genetic and so forth. Again, it's focused on common cancer types, or relatively common cancer types in making these estimates. But this gives us kind of an estimate about the total heritability, so to speak, that we might discover if we had the perfect tools. And so there is currently, using our technologies, GWAS and studying of highly penetrant rare syndromes like Leaf-Ramani syndrome and the BRCA mutations, about half of breast cancer risk, half of ovarian cancer risk, maybe greater, and half of prostate cancer risk is still unexplained and remains to be explained by these new coming technologies. So just to explain what the architecture of any phenotype risk, but particularly cancer risk, might look like, it can be regarded as a relationship between the frequency in a population of a particular allele that confers risk and the effect of that allele upon cancer risk. So there are 3 different categories. The first is the GWAS type, very common alleles that are present in 5+% of the population, which typically individually confer a very rare risk. And the other extreme, the stuff that Warthen described back in the early 20th century of BRCA1, BRCA2 families, retinoblastoma and p53. And let's not sort of trivialize this. We've learned an incredible amount about cancer biology in general from the study of these rare families. But what we're going to discover are these relatively, perhaps a little bit more common than these highly selected. These things are very highly selected against in the population because of their early onset cancer phenotypes. But there are going to be alleles and other genes which have intermediate effects, much greater than the effects of GWAS, but we don't really have a sense of those because GWAS SNP platforms that typically only have not looked at these things that are present in a population at less than 1% frequencies. And getting an estimate about all of these and the interactions between them is going to be the challenge of the next decade, so to speak, or roughly a decade in terms of discovering the missing heritability of cancer. And this is the point I wanted to make about the current way in which we manage cancer risk. This is the popular patients who were referred into the Peter MacCallum Cancer Centre, Familial Cancer Centre. And then you see breast cancer, and here you see bowel cancer, and every other cancer type, including pediatric cancers and sarcomas, the disease IQ, which occurs 20 years younger than breast or bowel cancer, not represented at all. And this is not a genetic problem or a genomic problem. This is a clinical service, a health services problem for which all of us are responsible. I think if you pan back for a second and think about Jenny's talk, and talk about the incredible sort of range of unanswered questions and ambiguities and doubts that there are, one of the things that implies is that it affects almost every aspect of cancer care, all the way through to health service delivery, from the very simple elements of mapping cancer genomes in detail, about which I won't talk about today. But to give you an idea about what fraction of cancers we might expect to be able to look at, this is something I put together for males and for females in our community of the incidence, mortality, and the potential years of life lost for different cancer types. And I've coded breast cancer and bowel cancer in this blue fraction. So you see, if you look at females, about perhaps a quarter of the potential of the incidence of cancer in our community is breast or bowel, whereas it's actually even lower percentage of mortality and years of life lost, because we cure about 85% of women with breast cancer, thankfully. But if you look at the young population, people who are, and I don't have the stuff to show you, but if you look at the younger population, in fact these fractions are completely reversed. Because it's so rare in young populations, you find these other understudied cancers that are not getting referred to the FCCs are systematically biased here. And I suspect it's that population which we're particularly going to discover a lot about as we apply genomics to the population at large rather than to rare autosomal dominant families, where you get vertical inheritance and single genes causing cancer, as opposed to the complex polygenic contributions from those, especially those intermediate variants about which we've discovered so much. And just to illustrate that, this is a very summary shot of a study that we've been doing in our sarcoma population. And we've screened using only 70-odd genes, and these are class 5 American College of Medical Genetics pathogenic variants from a classification perspective. Class 4 are the ones which we predicted to be pathogenic on the basis of, say, fragment changes and others. And these are the missense variants which form the bulk of deleterious variation that we identify when doing those sorts of screens. This is in 780 population selected sarcoma patients, I should say. And you can see we've got an enormous number. In 780 individuals, we have well over half the cases carrying genetic determinants. And I think this is going to be the pattern. It could be argued that some of this stuff is not actually pathogenic except at the population level. And that's probably true. But even if one simply takes the group that are in class 5 and class 4, that's almost 20% of the cohort which currently is actionable. And I can tell you on this particular series, only 3% of the population were actually referred to an FCC on the basis of pedigree patterns, raising again the issue about education of professionals and appropriate management structures. Another thing that came out of our study was this, which shows that if you carry no variants, this is your age of onset of sarcoma, which is roughly 49 years in our cohort. If you carry one variant, it drops to 45, but if you carry 2, it drops to 40. If you carry 3+, it drops to 36 years. And 36 years, by coincidence, happens to be the age of onset of patients who carry p53 mutations, probably the strongest known cancer gene. So that suggests that, and you can see the numbers here are, you can't actually see the numbers here, but there are approximately the same number of individuals who carry 3+ variants in our cohort as there are remaining cases within sarcoma. And what that means is approximately, well, just roughly, it's likely that as much of a fraction of hidden, obscure, almost certainly a recessive in its transmission pattern, polygenic variation is going to account for early age of cancer onset, as we've currently identified in 100 years worth of familial genetic research. So I think this is just a hint about what we're about to see going forward. And the importance of this is we can use that information to help improve survival, because we can make our surgeons more effective. And this is data from Lancet, published in 2003, and there's been a review of this, but the general interpretation hasn't changed. This is the era of pre-mammographic screening for breast cancer in the UK, and this is in the era of mammographic screening, and this curve here is in that same era, but the people who weren't screened. So you can see a very significant effect upon survival, around 20%, simply by detecting cancers at an early stage. And it's not just breast cancer where it's been studied, as I pointed out before, but also bowel cancer. And then there's also the opportunity for using relatively well-tolerated drugs to try and reduce the incidence of cancer by prevention, things like aspirin and potentially using hormone therapies. And just to sort of give you an idea about where this might lead, this sounds like it's a recipe for causing an increase in public investment. But this is a distribution of relative risks for women with breast cancer. This is the risk increased over the average for one with a first-degree relative or a second-degree relative, with cancer under the age of 50. You can see that increase in risk, and this is not genetic information, this is clinical information. And so we can take that population and then perhaps target our screening programs more effectively, remembering that we currently screen women over the age of 50 across the entire population. But what happens if you're dealing with a population that is at less than average risk? There are women out there in the community who are very unlikely to get breast cancer. And maybe what we should be thinking about is we map the enormous investment we're going to make in the healthcare system onto our strategies to try and improve survival, remembering that the elliptical curve of targeted therapies ultimately meets on the x-axis. We want to improve survival, we're going to have to think about other approaches, immunotherapies, combination therapies, and this sort of approach which tries to take things to a curable stage. And actually part of that may be made affordable if we shift our investment from a population that is not at risk, actually at less than average risk to those that are carrying the highest excess risk. This is the cost of mammographic screening as far as I could tell it. There's around $120 million invested in 2006 or 7 in the total cost of breast screening. If we were even to reduce that by $30 million and put that into potentially a screening program, what would that mean? And now clearly, I'm not saying that that's necessarily going to be of benefit, but I'm saying this is the sort of question that we should be asking, at least the public health system. Because one thing is for sure, if all the things that we've talked about, the protein consequences and potential applications of this view of cancer apply, it's going to cost a fortune for us to be able to realize this. And so I think it's incumbent on us to think creatively about where we should be putting those investments in the most effective way. And I'm going to finish off now with just one little study where we're trying to translate our genetic information to things that will help. And this is using a new technology, a codependent technology in my view, which is whole body magnetic resonance imaging. One of the reasons why breast and bowel cancer have been well established in clinical practice is because they're organ-specific tumorigenesis syndromes, and we have mammographic screening, and we've had colonoscopic screening, and organ-specific prevention programs, i.e. mastectomy or colectomy for high-risk patients. So we can do things about it. That's why it's in clinical practice. Sarcomas or multi-organ carcinogenesis syndromes like Leaf-Romani syndrome, despite having been mapped even earlier than BRCA1 and BRCA2, haven't gone into clinical practice. But that's partly because we haven't had the ability to screen the entire body for early onset tumors. So this is a program that we're involved with, which is part of a global effort. Well, this is our Australian version of this study using whole body MRI in the P53 patients we identified in our cohort. And I want to just show this one result because we've only had 17 patients enrolled to this point. That's patient 5, 52-year-old woman who had a whole body MRI, and we picked up a surgically curable asymptomatic liposarcoma in her rectus muscle. And rectus spinal muscle, sorry. That woman went on to have surgery that was curative in principle for this disease, and yet if it had been allowed to progress to the point where it needed to be resected on the basis of clinical identification, would not be. At 17 patients, it is not proof that this will work, but to put it into perspective, the expected value of mammographic screening in high-risk breast cancer women is 3%. That is, you screen 100 women for every 3 cancers detected. So this is 17 and 1. And I think this may mean that we move out of the sense of futility about some of these syndromes and the sense that why do we ought to know about things we can't, it's like standing in front of a truck with your feet in concrete. What's the point of opening your eyes and seeing it coming? All it can do is add suffering. Well, suppose you can get out of the way. That's the reason that you open your eyes, and that's why humankind has evolved to the shape that it has. And I'm stopping here because this is just a creative exercise. We're doing things about this because this is where we see potentially something that make a difference. But I think pharmacogenomics is an incredibly important area. Ethnicity is genetic. They're not unrelated. So the fact that you have variants that are present in the Taiwanese population is a function of the genes that assemble in that particular pool. And then what I think that tells you is it's not going to be a single thing like the simple class of enzymes. It's not going to be things about the tumor. It's going to be almost everything is going to affect xenobiotic handling. And things from obesity, genetic determinants of obesity will cause the fraction and so forth. It's going to be incredibly complicated. I think research needs to be done to try and map those interactions. And even in GWAS, I think interactions between loci haven't been systematically studied. That will take hundreds of thousands of people in probably the next few decades. But I have to say, I completely believe that this is an incredibly important area. And those of us who think this has become redundant, I've heard you say as much. Do you think that pharmacology may be dead? I don't agree with that at all. I just think it's going to take a while for everybody to catch up and reintegrate this into their view of human biology. Rare cancers. Now, we've talked about prostate cancer and breast cancer, but the greatest promise is going to be at least, this is 20% of all cancer incidents and 33% of cancer deaths, systematically ineffective, has a much higher lethality, and it's because it hasn't been studied. But molecular classifications offer rescue opportunities for these rare cancers, but the implications that flow from that, from the regulatory agencies, the way we conduct trials is a big issue which I won't have a chance to go into. And a really fascinating specific example of that is benign tumors. There are a whole range of benign tumors which are estimated to be 100 times as common as malignant tumors, a fraction of which cause severe morbidity, although not a high mortality, and which are very prevalent, although their incidence may be low because people don't die from it. And there are drugs being used on the basis of the molecular mapping of those tumors which completely change the risks, the pattern of risks and benefits to our community. Toxicities that we would tolerate in a person that's got 6 months to live, chemotherapies that have unimaginable consequences for patients, are completely unacceptable on a patient with a benign disease, which is essentially a chronic illness. And that's going to increasingly permeate oncology going forward. And this is the final point. I think oncology is going to morph into the treatment of neoplasia, and I think those numbers are basically radical underestimates. So I'll stop there because that's only just a snapshot into one small area, but there are so many areas where I could imagine making a difference to the patients that we treat at both the individual and also the population level. Thank you.